Good morning, everybody. Thank you for joining us today. The title of the Grand Rounds this morning is the Self-Assessment for Modification of Anti-Racism Tool, Addressing Structural Racism in Community Mental Health. I'm very pleased to introduce to you the two speakers from the American Association for Community Psychiatry and authors of this tool, co-authors of this tool. We have Dr. Rachel Talley, who's an assistant professor of clinical psychiatry in the Department of Psychiatry at University of Pennsylvania. She's director of the UPenn's Community Psychiatry Fellowship and is also an associate program director for their adult residency training program. She leads several equity-focused initiatives at UPenn. This includes programs called the Spaces of Color program and the Brain Research Advancing Inclusion in Neuroscience program, and works clinically with individuals with SMI at Horizon House. She received her bachelor's from Harvard University, MD from Stanford University, and completed her residency training and public psychiatry fellowship at Columbia. She's a member of the board of American Association for Community Psychiatry and the National Council for Mental Wellbeing Medical Director Institute. Our second speaker, our co-speaker today is Dr. Shoyinka. He's Chief Medical Officer for the Department of Behavioral Health and Intellectual Disability Services in the city of Philadelphia. In this role, Dr. Shoyinka leverages health system policy and process improvement strategies to assure optimal population health for the roughly 1.6 million citizens of Philadelphia. As CMO, Dr. Shoyinka led redesign of Philadelphia's crisis system, including preparation for the implementation of 988. He's co-developer of this SMART tool and facilitates self-directed work with other organizations. He's trained at Yale, Columbia, and NYU and is triple board certified and holds a master's in business from the Kelley School of Business. He's a fellow of the Philadelphia College of Physicians and serves as volunteer faculty at UPenn. They have many other accolades, too many to tell you today. I'll leave it there and hand it over to Dr. Talley and Shoyinka to give us their presentation, and you can feel free to add questions as we go along, and we'll pick them up at the end. I want to give them my personal thanks for joining us. They've been very generous with their time over the past couple of months, visiting with us virtually at UCLA and at Resnick as we have been working to utilize this tool for our own hospital. Thank you very much for joining us.
Thank you so much for that warm introduction. And we are both delighted to be here this morning to present this work. So again, I'm Rachel Talley, coming from the University of Pennsylvania, and we are here to present the Self-Assessment for Modification of Anti-Racism Tool, or the SMART. And this will focus on addressing structural racism in community mental health. So first, a couple of disclosures. I'm a medical advisor for an early stage startup, Vana Health, and Dr. Shoyinka is the founder of Sentia Health, and none of the content in this presentation is relevant to those roles. And we'd also like to acknowledge our friend and colleague, Dr. Ken Minkoff, who is another co-author of the SMART tool, also a board member of the American Association for Community Psychiatry. So to start out, I'm going to start out our presentation with a little bit of sort of level setting as far as the inspiration that brought us to creating the SMART, as well as share some of the process of its development. And then I'll be turning it over to Dr. Shoyinka to walk us through the steps for implementing the SMART tool, as well as a real world example of implementing SMART principles in the crisis system in Philadelphia. But to start out, I want to bring you back to 2020, which of course was a year of tumult and chaos in many ways, with the rise of the COVID-19 pandemic, but was also a time of a sort of a revitalized national conversation around issues that, of course, far predated that year. And these are issues of structural and systemic racism. Much of this dialogue, of course, was kicked off by the highly publicized killings of unarmed Black Americans at the hands of the police. And so as members of the American Association for Community Psychiatry, and for those who aren't familiar, the AACP is a national organization that represents psychiatric providers in public and community spaces across the country. We, like many healthcare organizations, I think we're left sort of grappling with this question of what to do around this dialogue. What was our role in terms of addressing these issues, and where could we, particularly as folks working in spaces with the most marginalized individuals in mental health, with our marginalized patient populations, how could we really think proactively about addressing structural racism as it manifested in our spaces and our work? And so at the time, the American Association for Community Psychiatry, like many healthcare organizations out there, released a statement basically decrying structural and systemic racism, decrying police brutality. Here on the screen, I have 4 commitments that we concluded our statement with. And our goal with these stated commitments was to really frame this idea of encouraging our membership to not simply talk the talk, but to really walk the walk and go beyond simply that conversation around structural racism to think about what we could proactively do to address these issues. So of course, having released this statement, then the question becomes, that's a proactive statement. We are stating an intention to walk the walk. How do we go about doing that? And particularly how, I think a question for those of us who are members of the board of this organization, how do we as the leaders within this organization provide support, provide tools, provide something to assist community mental health providers across the country in walking that walk and being proactive in addressing structural and systemic racism? And so following from that, where our thinking went, and what I have here is sort of the goals we had in mind that ultimately became the SMART, was at first we ideally, knowing that that structural and systemic racism are issues that impact, frankly, every facet of society. There can be a feeling of where does one start, that we wanted to ideally provide something, provide a tool, provide a support that would zero in on issues specific to the community mental health setting and issues where disparity might be highly relevant within the community mental health setting. Knowing that for our busy on-the-ground members working in these community mental health spaces, that it could feel overwhelming to try to address structural and systemic racism as a whole. Our hope was to create a tool that would ideally address issues that sort of are likely to be in one's own backyard if one is a community and public and community mental health provider. And so I'm going to jump ahead a little bit to give an example to sort of crystallize that idea. For instance, among the issues that the SMART tool addresses, we have a realm where we look at clinical care issues. For clinical care and community mental health, that could cover that. Where does one start? There's so many issues to consider. But we specifically zeroed on issues such as, for example, access to clozapine. This is an issue we zeroed in on, one, because it's uniquely relevant to the public and community mental health space, spaces where we primarily see folks with severe mental illness, where we might expect that clozapine is being utilized more often than in other clinical spaces. And because there's copious literature evidence suggesting that clozapine is underutilized amongst racially and ethnically minoritized populations, even when one accounts for other factors. And so again, that's fast forwarding a little bit ahead in terms of what the SMART looks like. Dr. Shoyinka is going to be diving a little more detail there, but I wanted to sort of throw that out there from the beginning as far as the types of issues we wanted to ideally bring to the fore and encourage our members to focus on, issues that were both highly relevant to their settings and also issues for which the evidence would suggest that disparity and inequity, particularly impacting racially and ethnically minoritized groups, would be likely. Secondly, I'd say our second goal, how I might crystallize it in a nutshell, is that we did not want to reinvent the wheel we didn't want to reinvent the wheel or sort of be duplicative, knowing that we were by far not the first to come to work like this, that there is an array of rich existing work out there focused on addressing inequity issues in the healthcare space. We wanted to ensure that we were both reviewing and understanding the resources that are already out there, but then ideally creating something that sort of created a package for a community mental health provider, touching a group of issues that might extend a little bit beyond what was already covered in existing tools. And so in the second goal of extending beyond cultural competency and linguistic appropriateness to incorporate other aspects of structural inequity, that's a bit of a call out to one of the main key existing inequity frameworks that is out there, the class standards that address cultural competency and linguistic appropriateness, but is also sort of reference to the fact that while we wanted to incorporate incorporate the principles of frameworks that did exist, we wanted to ideally, if there was a gap, create something new that would be sort of uniquely tailored to the community mental health space and address structural inequity in all its facets as it touched that organization. And then lastly, I'd say goal number 3 is what really boils down to what the SMART is. We wanted to create a tool that would promote a stepwise, concrete quality improvement process that could be adapted for self-directed use in the community mental health setting. And I specifically emphasize self-directed use because a common experience that we as the creators, we as board members of the AACP had at this time was that I think like many around this time of 2020 when this dialogue came out, the common reaction amongst the folks that we were talking with and working with was a feeling of these issues are all encompassing, overwhelming. I'm not expert enough to address them. What can I, as a community mental health provider, as a community mental health organization, what can we do about this on our own? Let's see if we can bring in an outside consultant to address these issues for us. And our thinking was that that's not the wrong step, that there's who are we to prescribe what the wrong move is as far as trying to proactively address structural inequity. But knowing that bringing in an outside consultant in some cases could be just outright impractical for your standard community mental health setting, that these are settings where resources and time, resources in terms of financing and time really are limited, that it could be challenging to really support an outside consultant to address some of these issues. And so our goal was to ideally create something that could really empower the stakeholders on the ground in a clinical setting, those who, while they may not feel or feel that they are or be experts in structural inequity, are the experts in their own organization, right? Know the place from soup to nuts, know the ins and outs potentially of who's being served, how the organization is put together, what are its rules and regulations and policies. We wanted to really empower those stakeholders directly in an organization to be able to take some steps on their own, utilizing this tool to advance inequity work and do quality improvement work in the inequity space. So in terms of our process, and I'm going to move a little bit more quickly now to ensure we have time to really dive into the tool, what I'll mainly say about the process for the development of SMART, and we do have a publication in the Community Mental Health Journal that dives into this process in a little bit more detail, is that this wasn't a formal research process, but our goal was ideally to both draw on the expertise, the lived experience of our membership, which again is community mental health providers nationally, ranging from early career medical student members, resident members, fellow members, all the way up to senior clinicians and administrators, all different settings, rural, urban, whatever it might be. So a broad range we felt of true sort of on the ground experience of what it's like to be in community mental health and where inequity might be most prominently occurring in community mental health. So we wanted to draw on that expertise, but then also draw on the existing literature, research literature, to ensure we were zeroing in on issues for which there was an evidence base to suggest that inequity would be likely. And so basically our process that brought us to brought us to the SMART, helped us to develop the SMART, included a membership town hall where we invited members across the organization to attend and share their views on the current dialogue at this time in 2020 around structural racism and their views on what the AACP's role should be, what the key target issues might be as far as addressing structural racism in community mental health. We then had some further meetings of some of the subcommittees of our board to start to try to boil down some of the thinking that was shared by our national membership into a list of key target issues. And then we turned to the research literature with 2 goals in mind, both to review for key target issues that might sort of fit that box, as I just alluded to before, of both being uniquely relevant to the public and community mental health space, and for which there was repeated literature evidence of disparity and inequity for racially and ethnically minoritized individuals. And lastly, we reviewed the literature for existing inequity-focused frameworks utilized in the healthcare space, again, to both draw inspiration from existing work, but also to ensure that there wasn't something already out there similar to what we were trying to create, and to ensure there truly was a gap to fill. So Jen, I'm going to sort of just briefly reference some of these prior existing frameworks, just to sort of share examples of how we both aim to draw inspiration from what already existed, but then also saw a gap where something new could be created that could be of use to our membership, and we hope to the mental health community at large. So highlighting one of these examples from some of the excellent standards out there, which I will certainly emphasize to the group, please consider looking into these. And we do consider the SMART just one of many useful tools, we hope, for addressing inequity in the public mental health space. For example, structural competency. This is basically a set of 5 principles authored by Doctors Helena Hansen and Jonathan Metzel, which looks to sort of reimagine healthcare training in structural terms, pushing healthcare training to really think about those upstream social determinant factors and structural factors that may trickle down to create inequity and disparity for marginalized patient populations. And so I'd say we drew from this framework in terms of thinking about those upstream factors, particularly within one domain in the SMART entitled community advocacy, where we really encourage organizations to think about their partnerships with outside organizations that might get at some of those upstream social determinant issues that impact marginalized populations. We also have an item within our clinical care domain of the SMART that specifically addresses screening for social need. And so I'd say those are 2 areas in which we drew on and learned from the literature and work around structural competency to inform parts of the SMART tool. Where we found that there was still space for us to create something new is that while there's an array of excellent work that has been developed under the auspices of structural competency, as far as we could find in our review, primarily training materials for medical education for various types of healthcare professionals, nursing professionals, residents, medical students, et cetera, as well as some assessment tools for patients, for example, the structural vulnerability assessment. As far as we could find, there was not an organizational level quality improvement tool that had been created under the auspices of structural competency. So I highlight that as an example of where we both drew on existing frameworks, but found upon our review that there did seem to be a gap or a niche that we could fill with what we were trying to do with the SMART tool. For the sake of time, I'll move on, but again, to highlight the rest of these frameworks here is just sort of a sampling of some of the other existing frameworks that we noted on our literature review that helped to inspire how we thought about and put together the SMART tool. And with that, I will turn it over to my colleague, Dr. Shoyinka.
Thank you, Dr. Talley, and good afternoon, everybody. It's a pleasure to be here with you all. Thank you for inviting us to share our work around the SMART tool. And I want to extend that appreciation specifically to Dr. Chung and the leadership team here at Resnick. Now, picking up from where Dr. Talley left off, and just sort of echoing some of the things that she mentioned, oftentimes when the conversation around structural racism really sort of commences there, and people start thinking about, well, what can we do? How can we, change this, or how can we address these issues? There are a number of common pitfalls that organizations can fall into. The commonest is a dismissal of the possibility that structural racism exists. So it's, we are good people here, that sort of thing doesn't happen here. Another common pitfall is the idea that, where do we, as Dr. Talley mentioned, this is so overwhelming, where do we start? Where do we even begin doing this work? And people sort of get overwhelmed and don't do anything with it. Thank you. And then the last pitfall commonly is to attempt to train our way out of it. So there's almost a default that, well, if we just teach people enough about structural racism and we, provide them literature and whatnot, then that will equate to behavior change at the organizational level. And the evidence does not suggest that that is effective. And so SMART offers a new way, a different way to approach the issue of structural racism, which of course is a set of practices that are embedded in real day-to-day operations in any organization and that drives these negative outcomes. So SMART, basically, to reiterate what Dr. Talley said, uses continuous quality improvement methodology to tackle racism. It views structural racism as not a moral issue necessarily, but as an issue that impacts the level of quality that the organization is attempting to accomplish, specifically around the care of those marginalized populations. Now, a good place to start is what we call the serenity prayer of system change, which is really accepting that we cannot change other people, so we may not be able to do anything about society at large. We cannot necessarily even impact what other people believe or think, but we can actually do something about what happens within our wheelhouse. And then as has been talked about, it really relies on changing, identifying processes that drive structural racism, and then focusing on changing those processes. And of course, because of the nature of this work, it requires really taking a team-based approach. One of the beginning, and we'll talk about this when we get to what we did here in Philadelphia, using SMART principles, is to really identify your baseline. That is, where are we at today? And I'll just share a very quick comment. It can be frightening to take a look at where we are today. In fact, it's a common reason why, that organizations or individuals shy away from these discussions, because it can fly in the face of what we hold as true regarding ourselves as an organization. And so, but really it's the place to begin. The good news about this is there's always an opportunity to improve, regardless of where the organization starts, regardless of what those baseline scores are. The good news is improvement is always possible. And then obviously, we put here select an issue to address, because again, really coming back to that question of, well, this can be overwhelming. You probably want to select some low-hanging fruit to start with and then snowball that into bigger change. And we'll talk about how we did that in Philadelphia. Next slide. So this kind of just summarizes what I shared earlier. You want to move away from subjective impressions, the sort of discussions that can become heated and that can be so laden with emotion. And you move really to data, let's work with data. Move the focus from individuals, which that is important, but arguably less important than the processes that drive these outcomes. Generate data, identify areas where more data is needed. And again, I'll talk about that in our work in Philadelphia. And then really, one of the benefits of SMART is that it creates a way to have these discussions in a way that's focused on processes and process improvement, and really helps free people to really think about this creatively. The last couple of things are just, they're equally important. Now, we talked about the tendency to default to training. And one of the good things about SMART is you really learn as you go. And then the requirement to use scoring to facilitate these consensus scoring to drive group consensus is important, because what it does is it takes the level of the conversation to a much deeper plane. Let me just comment on that additional for a moment. I, as a senior executive in a county, in the city's bureaucracy, have a very different experience from frontline staff, or say even custodial staff, who may, not be shielded, should we say, in the same way from sort of how these policies play out. So it's important to have all of those things represented. Next slide. All right, so we talked already about this, but SMART really summarizes or distills the literature around the areas in which structural racism affects community mental health into these 5 domains. And the first of them is hiring, recruitment, and retention. Now, we know, I'll just cite a few items of literature there. So hiring, then clinical care, then workplace culture, which I'll talk about in a minute, community advocacy, and population health. Hiring is important because the policies are made by the, let's just say, by the people sitting at the table. So the direction for the organization, what the organization chooses to do, chooses to embrace, chooses to reject, is set by who's at the table. And as it is said, if you're not at the table, then you are on the menu. We know also from literature, I mean, oodles of literature was that there is disparity in representation at those levels, at the higher level. So I was stunned one day in business school when my professor of marketing just mentioned in passing, oh yeah, we know that, you know, people with minority sounding names don't get called back for job interviews. The literature has been clear on that for years. It was also, and then we sort of connected that to additional discussion around, well, the representation of minorities at senior leadership levels, managers, CEOs, and so on is something like 6% across the US. And if you compare that with roughly 33 or more percent in terms of overall representation, those are clear disparities. We also know that this holds true in academic medicine. We certainly know that that's true for women, but we know that the representation of minorities there's disparity there. One other area I should mention is discipline. If you look at the literature around referral to peer review or other disciplinary practices, it tends to minorities tend to be overrepresented. I mentioned these because these are clear. These are areas in which literature is clear that there's disparity, and by extension, these are opportunities for improvement, quality improvement. Clinical care obviously is where we all live every day. You know, this is kind of where the rubber meets the road, and we know again from the literature that there are plenty of areas in which there's disparity. Outside of mental health, we know, for example, that rates of cancer screening and pain management, obstetric outcomes, outcomes for infant mortality, we know that there's disparity in all of these arenas for minorities compared with majority culture individuals. Workplace culture we selected because it's this oftentimes can be this vague or seemingly nebulous thing, but it's actually an exceedingly powerful driver of behavior. So very quickly when you come into an environment and, you know, there are unspoken rules. There are things we talk about here, things we don't talk about here. There are things that are okay to joke about, for example, and things that are not okay to joke about. And the thing about culture is it's stably transmitted across generations. And so changing culture can be a powerful way to shape the behavior of everybody in the organization. And there are elements that speak to anti-racism that we can talk about. Community advocacy, because in public mental health, there's so much overlap with other arenas, such as, for example, the criminal justice system, such as, you know, other social services, child welfare, and so on. And psychiatry should have something to say about those arenas that impact the outcomes for our population. And then that brings us obviously to population level outcomes, which include things like mortality rates, incarceration rates, and so on, that again, are reflective of the care that we provide, or could be reflective of the care that we provide. So those are the SMART domains. We'll go to the next slide. And this is the SMART recommended process when a team is embracing this idea and really beginning to look at leveraging SMART, engaging SMART as a tool. And I do want to say that we've been really impressed by the level of work that's already been done here at the hospital here. So it really begins with a group conversation, and this has been done differently, in our experience consulting with different organizations. But one promising practice appears to be to have the senior leadership, as is done here, or has been done here, have the senior leadership really sort of make this a priority and commit to it. And as Rachel said, walk the walk, not just talk about it, but actually start to do the work. And then have frontline staff or staff really at various different levels of the organization select or be selected or volunteer into engaging in the work. And so that group really ideally should represent diversity, and diversity in many different ways. So diversity obviously in gender and and age and so on, but also diverse in this in terms of professional background, qualification, level, the level of seniority in the organization and so on, level of leadership, because that does really drive conversation. And it's useful to see this, and oftentimes actually is the case that beginning to use SMART does actually lead to deeper conversations. And I will say that in our organization at City of Philadelphia, our county office oversees services, all services and policy for Philadelphia County, for the city. In a system that already has such a high representation, it's like 44% of Philadelphians are Black, maybe another 13%. Altogether, we have maybe 40% are white. Even in an organization that has had that historical commitment to anti-racism, there was still opportunities, there were still discussions around inequity. So it's a useful tool from that perspective. And then obviously we've talked about consensus scoring. And again, where the rubber meets the road is selecting action items. And again, we'll talk about that in our work, when I talk about our work in Philadelphia. And then the real power in this is to not see it as a one and done. It's to embrace this as an ongoing sort of way of thinking, a way of life at the organization, with periodic reassessments. Next slide. So let's work through a few examples. So domain number one, as we said, is a critical domain because it really speaks to who gets let into the organization and ultimately how much influence and authority those people have in the organization. So it talks about recruitment, the process of recruitment, hiring, retention, who stays, who leaves, career development, who gets promoted, who doesn't, and disciplinary action, which I talked about earlier. Next slide. So in a hypothetical situation, let's say that the team here had made a decision to embrace SMART and start to do this work. And if the team says, well, we want to start working on domain number one. We want to look at promotions in our organization. So the question would be, to what extent does our organization track racial disparities in promotion practices, including time to promotion, percentage of employees of this background receiving promotion, and more importantly, to what extent are disparities being addressed? So a score of 1 would be, this has not even made it across our radar. We haven't thought about this. Score of 3 is, well, we actually have identified this as an issue. We've, say, for example, looked at our HR or promotion data for the last 20 years or 10 years, and we've looked at who came in the front door and, sort of what's happened to them since they've been in our organization. We've seen some disparities, we're concerned, and we've decided to start to do something. And so we've implemented committee, or whatever other process we've implemented to address this, and we've started to make some progress. Score of 5 is, well, we've actually eliminated disparities. We've, done our due diligence. We've kind of looked at our processes, and we put processes in place that from the point at which we've started to eliminate disparities going forward. And that would be cause for celebration. Yep, next slide. And a second domain, again, I would say for many organizations, this is often the easiest to really look at because there's so much data, right? We have our electronic medical records. Oftentimes we have paper records, it's easy to do chart reviews. So for example, around, and really get into quality of care and breaking down quality of care by, by demographic and so on. So these are the domains under clinical care: access to care, cause-based access, which is such a big issue, client engagement, client satisfaction. Again, we're actually looking at that in Philadelphia. Diagnostic disparities, which is huge, and there's tons of literature around this for decades around that particular item. Involuntary treatment, again, lots of literature around this. Social determinants and treatment disparities. Next slide. So again, in that hypothetical situation, being a group that's decided to do this, a sample question would be access to clozapine for treatment-resistant psychosis. And the question would be, to what extent does your organization track racial disparities in the degree to which individuals with treatment-resistant psychosis are provided access to and receive clozapine? And to what extent do we ensure that any disparities are addressed? Score of 1 is not on our radar. We haven't even thought about this. Score of 2 is we have actually started to track this. We have identified some disparities and have not made, but we've not seen any measurable progress. Our percentage scores have not changed. You know, we've not had any discussions about this and so on. Score of 4 is we've actually now tracked this consistently. We've identified these disparities. We know where the disparities come from, and we've made significant progress. This is not that hard to do, actually. We had one of our colleagues at the in the AACP who did this really just with her patient load. She noticed that all the Black men on her caseload were diagnosed with bipolar disorder, and they were all being prescribed Seroquel. And she thought, this can't be right. You know, she was supervising a number of nurse practitioners, and this cannot be right. So she went back and looked at each case with the team, and they saw, oh wow, you know, we're missing things here, and so they actually fixed it. Next slide. Workplace culture, like we said, you know, it's a powerful determinant of behavior, and it involves these different, I mean, there's more to it than this, but these are some core elements as far as anti-racism is concerned. Staff-to-staff conversations, which can be tense, but which also can be really productive. You know, staff-to-client conversations, which, you know, you know, this is not, it's fairly common that issues come up. Formal reporting and having a track or process to address racism and experiences of racism, intentional anti-racism, implicit bias training, structural training, and having a trauma-informed culture, understanding that racism is experienced as trauma by those that encounter it. Next slide. So an intentional anti-racism workplace culture. To what extent has your organization explicitly identified creating a safe space in the workplace for staff and clients to identify and discuss racism and its effects, as well as establishing formal processes as accountable individual structures and so on to achieve that goals? Again, same basic rubric. Score of 1. We're not thinking about this. Score of 3. We have formalized the goal, that is, it's made it onto our radar. We have discussed this. We agree this is an issue we want to address. We want to do something. We want to make a change, but we haven't really made any progress towards that change. And score 5 is we have a goal, we have a structure, we have a process, and we're making progress obviously as determined by that consensus process. Next slide. All right, domain 4, community advocacy, and these are some important areas: child protective services, elder care, law enforcement, housing and security, school to prison pipeline. Let me say a very quick word about law enforcement. In the city of Philadelphia, our office, the county office, DBHIDS, has for decades now had a significant amount of involvement in the criminal justice system and attempting to steer people with mental illness away from incarceration, because we know that's an issue. During COVID, we discovered because people were being released from prison and from jail, you know, to reduce the rates of transmission, we stumbled upon an interesting finding, and I say this just as a case in point. Our team created a halfway house of sorts, and what we found out that the people that were making it into the halfway house were, with all the best of intentions, there was a disparity in the representation of persons of color and versus white people who are making it into that program, versus those who are being released from prison and therefore eligible for that program. And it was such a shock to our team to discover that. And this is sort of the gap between intention and reality. And what we did was implement a SMART-like process, which meant you matched the percentage of people who are making it into the program with the people who are eligible for the program. And so corrected that. And I will just say that that's just an example of both the way that systemic racism tends to creep in and the way to address it using a SMART-like process. Next slide. So involvement with law enforcement, again, the same basic idea. To what extent do you work in partnership with law enforcement, local justice system, to eliminate disparities and in arrest, incarceration, diversion, and so on. Score of 1, we don't have a collaboration. Score of 3, we do have a collaboration. We have data. Score of 5 is we've identified this. We have processes. We're tracking data, and we've eliminated the disparities. Next slide. And domain 5 is outcomes and program evaluation, looking at health outcomes, looking at functional outcomes. Next slide. So functional outcomes, to what extent does your organization track disparities in functional outcomes, employment, homelessness, graduation, recidivism, and work to eliminate such disparities? Same rubric. We've just begun to think about this. We've not taken any action. Score of 3, we have formalized the goal of tracking and eliminating these disparities in population and outcomes, but we haven't really made any progress. And a score of 4 would be we have a formal goal. We've identified, we've developed and identify an accountable individual structure and have begun to make some progress. Next slide. So let me I already shared one example of applying SMART principles. I will share this other example of how we've leveraged this and actually built this into our crisis transformation. So Philadelphia's crisis system is, when I came to the city in 2019, Philadelphia has an excellent mental health system. But one of the complaints that came up when we started to look at gaps in the system and started to look at different aspects of the crisis system, one of the things that came up repeatedly was that people felt that what we call 302 is the emergency involuntary commitment process was too heavy-handed. We'll come to that in the next slide. But we also found out that people really really had some difficulty. We can go back for a moment, Rachel. We found that people really didn't have a good experience when they called the call center, when they called the call line. So we started looking at data. We looked at, we analyzed our data. When's the peak call volume period? What's the sort of the variation over the week and over the daytime and so on. So we looked at all of that, and that sort of was one of the pieces that kicked off our transformation. But one of the things we stumbled on in our transformation efforts was that there's disparity in people's experiences within our system. So these pie charts, the one on the left, it really depicts the percentage of people that call the crisis line. So this purple indigo big sort of section here, 67% are Black people. Whites that calling the line make up about 21%. Now, for me as an administrator, what this brings up are a number of questions. So we know from other conversations, other analysis in the system that, well, in part because of historical structural racism, there tends to be a clustering of indices of distress in the neighborhoods where you have high representation of Black people. So West Philadelphia, for example, has a high representation. When you look at old maps, you can see where redlining occurred, and you can sort of tie that to current day reality that people live in their experience. But we found out that a lot of calls, the majority of our calls to the call line callers identify as Black. So for me, that raises a question. Well, Philadelphia has a lot of resources. We have programs that target those neighborhoods. We have, call center, we have mobile teams, we have community mental health centers, call-based services and whatnot. Is it that those services are insufficient? Are people aware of them or not aware of them? Why is there such a, or is it perhaps because callers just find that the call center, staff are particularly helpful and it's an easy way to get their concerns resolved? So this raises questions. So this is an example of looking at your baseline and looking at it through a racial lens. Next slide. This is sort of what I've mentioned several times already. Yeah. 302 data. So I talked about how in Philadelphia, we know that there's disparity and there has been feedback from the city, from citizens on the experience. So when you look at on the experience with 302, so when you look at this far right column, you can see that there's already some disparity in representation within Medicaid. So 50% of Medicaid eligible individuals qualify for Medicaid. When you look at people that end up on a 302 and emergency involuntary commitments, it's almost 58% of those persons identify as Black. And when you go to the next slide and you look at the reasons why people are 302'd, and you look at the perceived risk of harm to others. So essentially, more Black people are 302'd and more Black out of, when you look at that population that's being 302'd, Black people are basically considered to be at risk or at risk of harming others disparately compared to the other populations. Why is this important? Because we had the shooting death of Walter Wallace in Philadelphia, which was one of the things that really kicked off our crisis transformation efforts and kicked it into high gear. Well, that death occurred because in the context of a young man who was in crisis, living in West Philadelphia, whose family called 911 for assistance. They called several times that morning. When the response arrived, it was a law enforcement response that ended in that young man being killed. And when you talk to dispatchers, they will tell you that the tone of what they get, the information that they receive, really sort of translates or gets transmitted across to the law enforcement officer. So if the police officer thinks, I'm going to rescue the public from this person, it's a very different mindset than going out and say, well, I have somebody who's in danger, or who is themselves impaired, and I need to go help them. I'll stop with that, and I'll hand it over to Dr. Talley to wrap us.
Right, so we just have a comment or two to wrap up before taking some of the questions that have been sent. First, I'll just briefly highlight again for those interested in that deeper dive into our development of the SMART tool. This is the publication where we discuss that. And then lastly, I'll emphasize that for those who have an interest in taking a look at this tool and seeing its value to your organization, we're so excited that some of the programs at your institution are actively looking at applying the tool. It is freely available at the website for the American Association for Community Psychiatry. And just in terms, I'll say briefly in terms of future directions, we're in the process of creating a more robust training series to go through the SMART domain by domain for more robust technical assistance for folks implementing the tool, as well as looking towards convening a learning collaborative utilizing the Project ECHO model. And so with that, I will go ahead and stop sharing my screen, and we're eager to take questions and comments.
Thank you, Dr. Shoyinka. Thank you, Dr. Talley, for giving us a very brief but comprehensive overview of all the work that you and your colleagues have done on this. A couple of reflections just from my own mind to begin. When you gave the introduction and prelude to how you got here, I think it resonated with me and probably with many people. Where we have been and where we're going has felt all-encompassing, overwhelming. I think that was your terms. How do you take on some of the work in the project of addressing systemic racism and inequities? What can we do about this on our own is what I think a lot of people have been asking. And this tool has given us a ability to look at that. It's self-directed, it's continuous quality improvement, as you said. It speaks the language of a lot of what we have been doing already, but it puts it into this new domain or important domain that hasn't gotten as much attention over time, and it's highly organized with metrics and data points, and it's adaptable. I mean, so you've really created something that is very applicable for many of our clinical settings. One more thing that I think jumped out to me during your presentation is the concept of training our way out of this. And I think it was Dr. Shoyinka, one of you was saying, it's probably not going to happen that we train our way out of this. We need concrete steps, looking at processes, looking at data and processes. And I think your tool has helped to provide that template. So first question is, are you able to give some examples of perhaps different organizations or different applications of the SMART tool? I know originally designed for community psychiatry, but anything that you can shed light on in terms of adaptations that people have been doing so far?
Yeah, absolutely. Well, I'll say first, in terms of, to your point about adaptations, one thing we're very mindful of is that this tool it's rather extensive. Even with the length of it, we haven't even touched a vast array of issues that could be relevant to consider in terms of disparity in the community mental health space. But some different iterations that we have seen have certainly been taking one portion of the tool and just drilling down on that. Particularly, I'd say hiring, recruitment, retention, and promotion, as well as clinical care, are the most common domains that we've seen folks organizationally focus on. As far as setting, in terms of expanding beyond community mental health, we've seen sort of the whole array in terms of academic medical centers, local and state mental health authorities. We've had some interest from payer organizations as well to think about ways to utilize all or part of the tool and sort of embed it into their processes to start to track disparities. And another piece on in terms of even the process and thinking about little sort of tweaks and iterations that can make it more adaptable to the work setting. Of course, we lay out in the tool that the ideal process is to bring together a set of stakeholders from a range of identities, as well as professional roles and sort of levels within the hierarchy of the organization. I think a very real sort of challenge that many organizations upon applying the tool have run into is how difficult it can be when you bring in, say, folks on the front line who may be mindful of that power differential to have a conversation, say, with folks in upper leadership around structural racism and whether they feel they'll be able to be fully straightforward on their views. And so some sort of iterations that we have seen have been both, say, separating upper management and folks on the front line to do the SMART separately first, and then coming together to sort of share their findings in that sort of anonymized way where there's still the shared conversation, but a little bit of protection for folks who may not have that same level of privilege as those with upper management. We've seen that both in a clinical setting, in an academic medical center at New York, as well as one in Philadelphia, where there's the comparison of basically the chair's office completing this relative to folks more on the ground. We've also seen a permutation where one organization actually changed the SMART into sort of a Qualtrics style survey, sent it to all employees in the organization, did it in that sort of individual way to get that feedback from every person in the organization, had everybody individually fill it out, and then convene a stakeholder group to look at those results. And so it was a way of sort of still having that stakeholder conversation of trying to come to consensus, but being sure to take in the views of the organization truly as a whole. So those are a couple different permutations we've seen as far as process, and certainly we've seen folks use parts of the tool.
Got it. A couple of questions that are coming through from some of the viewers. So this is a question specific to an example that I think Dr. Shoyinka, you were giving. In the specific case of drug disparity, the question is, how did they change it? For example, did they talk to physicians and ask why it was done by a physician? I can't remember what was being referenced then. Anything that you can share about the reasons why that were understood around the drug disparity?
Pardon me, I didn't hear you. Did you say drug disparity?
Yeah, that's what the question is referencing. I think it was a portion of your example that you were giving.
Oh, I see this, the medication management.
Mm-hmm.
It's a good question. What our colleague discovered was she oversees a panel of nurse practitioners. And what she discovered was this sort of, as I mentioned earlier, this tendency to diagnose a certain population with with a specific diagnosis and then treat accordingly. What was done was to really sit down with the providers under her supervision and review cases individually and sort of query the diagnosis, on what basis were these diagnoses made, and so on. And then in instances where it was discovered that those diagnoses might have been inaccurate, then the appropriate adjustments were made to both the diagnosis and the treatment.
Got it. There's a similar question about one of your examples, and it was referring to the prison release shelter disparity, I think accessing shelter or housing after release. And the question is, was the team able to see whether and conclude that it was systemic racism, or were there processes that folks were not aware of, like how to fill out forms, or gaps that were along the way that might not be attributed to distinctively systemic racism?
That's a very good question. So the individuals themselves were not filling the forms out. It was a joint process between the prison officials and our team. And so it's not clear entirely how it came about that there was a disparity between in the representation of the eligible population and the people who eventually got into the program. What is interesting is simply making that disparity known, making it obvious and making it known, and having a discussion began to correct the disparity. So in other terms, if we were going to use psychoanalytic terms, it would be the equivalent of making what is unconscious conscious. And creating an opportunity for transformation, which is what we saw.
Got it.
And if I could hop in with a quick follow-up, knowing that we're short on time, I might challenge a little bit that distinction between, was it systemic racism or was it processes, right? Because at least how we're thinking about systemic racism is that this isn't necessarily about individuals within those teams saying, well, we don't want to give the minoritized folks this service and consciously sort of manifesting that interpersonal racism. We think of it more as that processes will be put into place by well-intentioned individuals who are intending for them to be distributed equitably, but because of ways in which society may be set up, historical, structural factors, those policies may trickle down and impact folks differently. And that it's important to sort of note that there's a disparity, whether it wasn't intentional or not, and often it is quite unintentional, and find ways to sort of adjust those processes, make improvements to those processes to try to eliminate disparity that upstream factors may be creating.
Yeah.
Well, I'll just do that. And that's really the power of data, right? Because it changes the conversation. Go ahead.
Yeah, that's such a, I mean, both of you, that's such a critical, I think, valuable response to that question. Thank you very much. Maybe just one more thought here. As we have internally and in our own hospital begun to look at this very in depth and restructure some of the questions appropriately for our setting, adding, subtracting as necessary, I think that flexibility has been really great. And developing the data, I think, around certain areas has been the area where we realize, look, we're going to have to build some systems and structures. Have you seen that in other places too? It's like really from the beginning is harnessing data, making sure that you have enough data to watch this over time so you can really do a true quality improvement process on it.
Yes, I can offer the examples that I gave already, the work that we're doing around crisis. Obviously, we had the opportunity of that being a new effort, so we could really build it in from the ground up. But with respect to hiring and promotion and so on, I can offer the example of our organization, which over the last about 3 or 4 years has really embraced a full court press around, and so done analysis, the same sort of analysis that I talked about, looked at who's hired, who's promoted, who's tracking that over time, and then really just sharing that quite openly with the rest of the organization and having these conversations So I can offer DBH ideas as a model for doing the, we actually have a team that is wholly devoted to equity work and does nothing else.
Phenomenal. Well, we reached the end of the hour. It went by very fast. I want to thank both of you for spending the time with us and for sharing all of your insights and experience and knowledge about this topic and for developing such a valuable application for people to use. Really appreciate it. And thanks so much. And we'll be in touch.
Thank you.
Thank you.
All right. Take care, everybody.